So I think just to kick things off, if we kind of both introduce ourselves, I'm Daniel. I'm an academic foundation doctor at St. Thomas's in London. Rebecca? Oh, I think you're on mute.
Oh, sorry, I'm Rebecca. I am an academic foundation doctor doing FA1 in Southampton, Wessex.
So the point of today's panel is mainly a Q&A for people in the audience to ask a bit about how AFP interviews work, how you might want to prepare. But I think to start things off, maybe if each of us talk a little bit about our own experiences of our AFP interviews, because they're only around this time last year. I'm aware that for people going through the process this year, obviously things will be very different and a lot of the interviews will probably be online. But Rebecca, why don't you kick off and tell people a little bit about kind of your interview experiences?
Sure. So I applied to both North West England and to the Wessex Deanery. Both of them obviously were in-person interviews in December of last year. In Wessex and in North West England, they were both 3 short interviews. So in Wessex, it was 10 minutes each. There was 1 clinical station, and then a couple of stations about why you wanted to do the AFP, your experiences in research, and a bit about research in general. And then in North West England, again, it was 3 stations, but I think it was 15 minutes each. And it was a bit more similar to the London interview in that there was a critical appraisal, a clinical, and a station about yourself and about your experiences and why you wanted to apply to the AFP. But yeah, it was generally a very positive experience and I learned quite a lot from it.
Mine were fairly similar. So I applied to North East England or Northern, as you might find it detailed online, and London as well. Both involved 2 stations each. London was 2 10-minute interviews. 1 was clinical and 1 was academic, basically a critical appraisal. Meanwhile, in Newcastle, in the Northern Foundation, 1 station was also clinical and 1 station was more personal, looking at why do they want to do an AFP and my own previous experiences in research. I'm aware for a few people in the audience, when we say kind of clinical station and academic station, that might not mean too much right now. Do you want to maybe shed a bit more light on what we mean when we say clinical?
So the clinical station tended to take, for me at least, the shape of kind of an emergency situation on the wards. You'd go through it in an A to E format as you learn in your final couple of years of medical school, and you just explain what you would do to approach that certain situation. So I'm going to give an example of someone having an allergic reaction, and you'd go in and they would tell you what the patient has symptom wise, what's happened. A nurse has called you to the ward because patient has just had some penicillin and now they've developed breathing difficulty and they're worried about it. So then you would go in and say what you would do from the moment that you're told about this situation until the moment that you've decided on what's happening and how you would treat it. They can stop you and they can ask you questions, and it's kind of difficult to prepare for what they're going to ask you. But I think if you go in and you know how you're going to escalate it appropriately, you can solidly answer and practice your A to E approach, then generally it's quite an easy station to do well in if you've done your practice. And my top tip for that would be to look at the back of the Oxford Handbook, because there are so many emergency scenarios there. And if you talk through it with your friends then and practicing your interviews, then you probably could score really, really well on it. I don't know whether, Dan, you have anything to...
I completely agree. I think from the clinical side, the main thing you need to go in and read is probably the back of the Oxford Handbook, the back of the cheese and onion. With the clinical stations, they're never going to ask you weird and wacky. It's going to be common emergency situations that you're likely to encounter as a F1 doctor, and the back of the Oxford Handbook goes through what most of those are. So there's really a finite list of what can turn up. And if you've practiced different clinical stations, you can do it by yourself, you can do it with friends, and you can say, okay, a patient has had an episode of hematemesis. Tell us what you would like to do. And if you'd practiced a couple of times talking through how you'd approach hematemesis and you get it in the interview, you're pretty much set. Because that's basically the way to, let's say, pass the interview, is to do an efficient A to E that shows clinically you would know what to do and that you would be safe as a doctor. There are a few challenges that can come in, like Becky said, that they can interrupt you midway and ask a question that might throw you off a little bit. Any challenges you encountered in your interviews?
I think in my interviews at the very end, they kept asking me what I would do next. I think there was a scenario where I couldn't escalate to the med-reg, I couldn't escalate to surgical teams, and I don't know where they were going with it, and I never got the answer, but I still got an offer for the place. So I can't remember them actually interrupting me and asking me questions that I wasn't able to understand during the scenario itself. But I remember at the end they had a list of questions of how I would escalate it, and generally I was able to answer them. However, the very last question that they had, I have no idea what they were getting at.
Mine was quite similar. I think right at the end I got a question about how you would investigate osteosarcoma, which I had no clue what to say. And often you find that in a lot of interviews, those couple of questions at the end are designed really that oh, you've done well so far, we're just going to push you that tiny little bit further. So I think a lot of you in the audience today probably have done MMIs when you applied to medical school, and there's a lot of overlaps there. Just because you get one question that throws you off does not mean you failed the interview. I think it's important to be a bit resilient, and if you get something you think, I don't know what's going on, it may be just a challenging question. It may be that you need to ask for a bit more clarification, and that's absolutely fine to do so as well. And that you keep going and you don't kind of let things spiral, that one question leads you to kind of freak out and shut off from what they're telling you next. I agree with what we said earlier, that knowing your A to E is the core part of the clinical interview, but as Becky's kind of alluded to there, what they eventually go on to with a lot of these clinical questions is not just, do you know what investigations do you know how to interpret the investigations? Maybe the last half of the interview is more about, well, how would this work in real life? So like you mentioned, oh, your SHO or your registrar is not available. What would you do? Because those are situations you'd come across as a doctor. And so they're not just testing, do you know how to treat hematemesis, but do you know who to contact? Do you know who to contact if that person is not contactable? And so I think what separates a good performance in the interview from kind of an amazing performance in the interview is being able to show off a bit of how would it actually function in real life. So as Becky said, kind of escalation, knowing that actually I can't deal with this by myself, I need to go to someone. What are the routes of getting in contact with that person? So let's say a good example is they might tell you at the start, oh, you have several patients you need to go see. Someone who's got the hematemesis, someone who is complaining they're in pain, and you might have to prioritize who you see. And it might be like you're kind of on call as a doctor. So things that, again, would show you can imagine what it's like in real life. If you're sat in the doctor's office and you're waiting to go see a patient and a nurse has called you to come see them, there are things that the nurse could be getting on with whilst you're on your way. So say if someone's having chest pain, you'd probably want to ask, well, could you do an ECG whilst I get there? Because that's going to be one of those key things you're going to need to decide how you're going to manage that patient with chest pain. Yeah. Anything you'd add on that?
No, I think it obviously accounts for different amounts in. So in London it may account for more because there's only 2 stations, but I think in some of the places where I was looking at and applied to, the clinical station can be a cut-off. They just want to see that you are a safe doctor and you're going to be a safe F1. You're not expected to know any more knowledge than you were expected to know for finals, but the knowledge that you do learn from the back of the Oxford Handbook, I thought was immensely helpful for my finals, because we had an A to E scenario in my final year OSCE, and I was so well rehearsed at it just from speaking through it in the interview that it was really, really helpful in the whole. And I also had another tip from people who told me last year about how to prepare for this station, and is to look at the A to E as I would measure, I would assess, and I would manage for each part of the A to E. So the airway, obviously you can't really measure anything for the airway, but I would assess the airway. Is the patient talking? Can I hear any signs of stridor? Is there any evidence of obstruction? And then you would manage it. So if there's any signs of airway obstruction, then you would say, I would get anaesthetists involved. I would put in a Goodell airway. I would do simple airway movers, and do that for each session of the A to E. It's really, really helpful just to have that structure, because even when they do interrupt you and ask you to clarify something, you think, oh God, where did I get to? I was on B. And it's just really easy if you said, okay, I was on B. I already said that I was going to measure the respiratory rate and the saturations. Now I'm going to say I would assess. And I thought that was really, really helpful.
Having a structure is really important for when people jump in and try and not necessarily catch you out, but there are some interviewers, like we said, who will give you the problem and will just let you talk and talk and talk for over 5 minutes straight without interruption. And that's why having your spiel, being able to talk through it like that is really useful. But I think when you're practicing as well for the interviews, if you're practicing groups, do also practice where one of you is that interviewer who keeps cutting in. So like Becky said, you can kind of figure out where was I in my head and then kick back off from there.
Yeah.
I think that's probably the main things to touch on for now with the clinical interview of Oxford Handbook. Definitely, I think anyone you talk to would probably recommend that. Having that structure, but then also being able to show off, if I was actually on the wards, what is it like in reality? So it's easy to say, oh, I would get this test and this test and that test, but understanding, okay, what can I get now? So it might be, for example, getting a blood gas, an ABG, a VBG. Really, really useful in an emergency situation, because within 5 minutes, you'll have a lot of different biochemical results, but obviously you need to know yourself, well, what can I get from a VBG or an ABG? I can't get someone's white cells to see if they're infected, but I can see, okay, if their lactate is high, I can see, have they got an acidosis, an alkalosis? So stuff like that is quite useful. In the audience, in the chat, any questions on the clinical side before we then move on to some of the other things you might encounter? As people are typing, I don't know if there's anything you want to add, Becky.
No, I think we've covered most things. Obviously, if people have questions, I'm more than happy to answer them. But I think preparation is probably key. I mean, there is a danger of being over-rehearsed, maybe. And I think many people probably do show up over-rehearsed. But it does also show that you're going to be a competent F1 if you know what you're talking about, and you can go in there and confidently say, I know how to manage this emergency situation, and I know how to safely escalate, and you will be a safe F1.
Would they bring in communication stations like BBN? So what do you mean by BBN, sorry? Breaking bad news. Yes, okay. So for my two, I never had to do kind of any role play, but I do believe some others had difficult communication stations. So I think it's probably important to check kind of with people who've been through that interview before. Did they get anything of the sort? Teaching stations, I'm not sure I've encountered anyone who said they had a station where you might have to kind of pretend to teach someone. But it might be, yes, that you have to put into simple terms to the patient or their relative what's gone wrong, what they've come in with. So breaking bad news, I wouldn't make it the mainstay of your prep, but I think depending on where you're applying, I think maybe East Anglia, if I remember correctly, did have something like that in the past. What I did have with mine, like we said, they want to see how things function in an actual hospital. Attached to my clinical station, there was also a quick discussion about, a patient had an investigation, they had a biopsy that showed they had cancer, and the biopsy was never properly reported. So they've only found out that you've only found out about this 2 or 3 weeks later. Please talk us through how you would chat to the patient and their family about this. And then from there, they then segued into a long discussion about what would you need to do when a mistake like that happens. So, for example, filing a DATEX, about duty of candor conversations and telling people, making sure people are properly informed. So that the clinical scenario can have a couple of questions at the end that go into sometimes what we might call ethical or professionalism themes. So I think those are worth understanding, and I think there's a huge overlap with the SJT actually. So if you prepare for the SJT well, it's pretty much like talking through an SJT question. Anything you'd add to that?
I haven't had much experience in interviews. I think I knew that generally the clinical station in where I was applying, I think just looking at the information, I was going to be expecting an A to E situation. But like you said, I think preparing for OSCEs if they're coming up and for the SJT will help for any ethical scenarios. I think the only communication element to my clinical station was more so handover, how to succinctly hand over a patient to your senior or to another team, and just use the SBAR format. And the stations only tend to be 10 to 15 minutes long, so you have to think that you have to tell them in a minute or two and just be as succinct as you can be. Yeah, sorry, I haven't had experience with anything.
I think one tip I'd give as well for those kind of professionalism style questions of you, as we said, it's rarely, oh, I'm going to pretend to be the patient, please break the bad news to me. It's more, imagine that the patient was there, talk us through the things that you would keep in mind. And a good way to start those kind of questions that might throw you off a little bit, rather than jump in with, this is what I would do, is to talk about the different factors involved. So one I had at my Newcastle interview, they posed the question, imagine you're in F1, one of your colleagues is constantly being basically bullied on board rounds by a senior in front of patients and in front of you and other colleagues as well. What do you do? And that's a challenging question. If you just jump in with, I'd go to the GMC, then you probably make mistakes rather than say the right thing. But it would be easier to say, well, what do you need to keep in mind here? You need to keep in mind, do they actually want you to do something about it? Who is the right person to go to? How long has this been going on for? And then essentially just talking them through step by step, the pros and cons of different things you might do. So that's the clinical station with a little bit of professionalism ethics that we just mentioned there. Then the other probably most common thing you'd get is an academic interview, or what many call the research critical appraisal station. How did that work for you, Becky?
So in North West I did have a appraisal station, but in Wessex I did not. So the critical appraisal station, when I had it, it took the form of I sat outside the room for 5 minutes. They gave me some data from a paper. It wasn't a whole paper. It was just the data. I think it was a table. And they just asked me to interpret what I could see there. And then they had several questions to ask me. To be honest, it was probably my worst station of all the interviews. It was quite stressful. Just getting this information straight away. But I think there's ways that you can prepare for it. There was a really, really helpful book that I read last year. I think it's just an ebook. It's called Critical Appraisal for the Academic Foundation Programme. Super helpful. But I probably didn't prioritise preparing for critical appraisal as much as I maybe should have. And then for more academic stations, for places where they have white space questions, that's a really good preparation because you've already thought of the things that you might be able to talk about. They tend to ask you things about what research experience you've had in the past. So what projects have you done? What have you done with them? What presentations? Have you got any publications? And things that you can emphasize as being good achievements for you. Then they'll say, what would you maybe want to do with your research on the AFP? So why are you doing the AFP? you can have several reasons for doing it. It's very personal. You should probably just be honest. Whether that's just wanting to gain more research experience, whether you want to work with a specific person at that institute, if you have a research project already set up and kind of ready to go, if you were to get a job there, then that's really, it shows that you've taken the initiative to really dedicate some time to that location. And I think that they would really see that as being a very positive thing. And then after that, they tend to ask you where you think your career is going to go. So where could you maybe see yourself in 5 to 10 years' time? What would the AFP do for you in terms of your future career? So I think when you're practicing, just try to think of the questions that they may be able to ask you about your past experiences, your reasons for doing the AFP, and what you want to do in the long term. I just saw something I've forgotten. My mind's gone blank. I'll have a think.
I was just trying to remember what I'd say about the research one. Like you said, that there's kind of two ways it turns up. Either is a critical appraisal, where they'll give you some research to chat about. So for me, that in London, that was an abstract of a randomized control trial. And I think that's probably the most common sort of thing they might give you. And they firstly want you just to summarize and talk through what the abstract has described. So tell us, what is this research? And then pick apart what's good about it, what's bad about it. And just like the clinical one, a structure is really key. So a common structure people use for critical appraisal is PICO. So that's a good way to go through the elements of the study. P, population. So this is a study on men aged 55 and above with heart failure. Intervention, that's the I. So they were given a 10 milligram X dose of digoxin. And then C is control. What were the control group given? Were they given a placebo, or were they given perhaps the gold standard treatment? Were they given a beta blocker in this instance? And then O is the outcome. So what were we actually measuring in the study? Was it ejection fraction? Was it mortality? Was it morbidity? That's a good way just to start off with describing the study. After that, what they then want you to do is pick out the pros and cons, and a key thing is bias. So looking at things like selection bias, is it randomized? Looking at observation bias, so things like, is it a double-blinded study? Do the people know what they were taking or not, and what are the implications of this? And then towards the end, they often ask, well, what do you personally think of this research? Would it change kind of your own clinical practice? But I think the book Becky mentioned is one quite useful resource I've heard a lot of people talk about. And the one that's probably a bit longer, so it takes a bit longer to get through, is How to Read a Paper by Tricia Greenor. I read most of that, I'd say. And I think that's a really good book, whether you apply to the AFP or not. It gives you actually very good foundation in critical appraisal. I think at the end, we'll post all of these resources in the chat just so that people don't worry about missing them. But I think they're probably two of your key resources to look at, and then having that kind of PICO method. As for the personal side of things, which could either be, tell us about the research you've done in the past, what research would you like to do, or yes, just where do you see your career going? A good question, a good way to approach personal questions is another acronym, I know I've given you already quite a lot, is CAMP. So that stands for C, clinical. Where do you see yourself clinically in a few years? Is there a certain specialty? Is there a certain type of medicine? Then A would be for academic. So what sort of research interests might you have that you want to pursue over the next 5 years? M stands for management and leadership. So are there certain things that you'd want to get involved in there? Might it be, you might want to do things perhaps with the BMA, you might want to get involved locally with the hospital in some of the things that they do there in the hospital from a management perspective. And then finally, P for personal. So what do you want to do in your own personal life apart from that? And then it may then all tie into, well, how would this AFP help facilitate that? Do you remember what you wanted to say?
No, I think my other piece of advice was that I wanted to say everything that you mentioned, try to make it relevant to the AFP. So I want to do a PhD in the future. It's probably that's probably a bit generic to say. You probably wouldn't have more reason for wanting to do a PhD, but just say that you wanted to do a PhD in the future. And that's why you want to do the AFP now, because it will set you up for more research experience and more experience with balancing clinical and academic work. Yeah, I think just everything you say, try to make it relevant to the AFP and try to show them that that's why you are a good candidate for them. But there is a danger, I think, with the camp method, is if they've asked you a simple question and then you've gone on to a very long spiel for 5 minutes about what you want to do, and they have 4 more questions to ask you in the next 5 minutes, then just be mindful of how long you're taking to answer a question, because I know that I just waffle, and that was something that I really had to practice and work on prior to the interview, so that I didn't just go off on a tangent and end up not answering all the questions that they wanted to ask me.
Yeah, I completely agree. I think structure is quite useful, but if they can see you're going through that structure for every single question, not only are you going to take way too long, but it's going to start grating on them as well. I completely agree. I think questions like why AFP, the really common ones, is quite useful to have. Yeah. But yes, you want to make sure you're not just telling them things for the sake of telling them it. And I really agree. I think it's a good point that if you're going to say something, know why you're saying it. So you don't have to walk in there telling them, oh, I definitely want to do a PhD. But I think if you're going to tell them you want to, that's a good reason to then bring up the AFP, that actually balancing research time with clinical time is a challenge, is a challenge of being an academic doctor. And the AFP will give me that. That's a good way to kind of back up what you're saying. Or if you're saying, oh, I'm actually not too sure about a PhD, and that's why I want to do the AFP, to give me a bit of a taster of what research is like. So having a rationale behind what you're telling them, I think, is useful. And what they want to see is you haven't just done this on a whim. And I know a few of you in the audience might have. I think probably I did myself initially. But what they want to see is that you've sat down and you've reflected and thought about this decision, and they can see that in your answers. Yeah. We've got a quick question in the chat as well. Would you need any statistical knowledge? So how did you find that yourself, Becky? Do you have much statistics come up?
In the one appraisal session I did have some statistics questions. I think I had prepared primarily for a randomized controlled trial to come up. However, I think I had a COVID study come up, which completely threw me, and I think that's probably why it's my worst station. I wouldn't say you need to know tons, but probably knowing the definitions and how to work out things like number needed to treat would be really helpful. I just made some flashcards that I went through for a few days before, just so that if they asked me something in particular, then I would be able to answer it. So knowing how to interpret confidence intervals and p numbers, and they could easily ask you what is the p-value and why is the p-value relevant, because there's an argument that p-values aren't necessarily the best thing. So I say as long as you know the definitions and they can't throw you too far, and know how to work out, I think it's number needed to treat. What were the other ones in here today? I'm trying to remember. Can't remember. I think you need to have a basic understanding would be why.
I just say that no, you're never going to get questions on complicated statistics. So it's never going to be something like, oh, talk us through regression and how regression works. I have no idea how regression works. You might be able to understand why someone's using regression, but you need to talk about the actual ins and outs of it. But yeah, I think it's the bread and butter stuff. So they definitely could, like Becky said, ask, what do we mean by the term p-value? What do we mean by the term confidence interval? And you would need to, they're probably the 2 most important things to be able to interpret in a study. Any study you get are probably going to mention those 2. And then beyond that, it often comes down to the study type. But yes, I think understanding relative risk is one that might come up. Absolute risk reduction and relative risk reduction, relative risk, same thing. Those are two very useful ones to have. Mm-hmm. And then you need one of those to be able to calculate the number needed to treat. And it might sound quite daunting, but say, for example, I would never have thought I could calculate the number needed to treat before starting interview prep. And I think that's probably the same for most people, unless you come from a very academic background. But yeah, relative risk, absolute risk ratio, absolute risk reduction, odds ratios as well. But from my experience, I'm not sure anyone's ever been asked, oh, is this the right statistical test to use on this data? Reading about statistics is good for your own general knowledge, and it will help you if you want to go into research, but I think they're probably the key things. Understanding how we talk about risk, p-values, and confidence intervals. Those are the main things you're going to come across.
Ultimately, if you understand those, then you're able to fully interpret the data that they give you, and you're able to confidently make some sort of impression on the paper. And at the end of the critical appraisal, I don't know whether it was the same in London or in Newcastle, but I know that at the end of mine, I think they wanted me to make an impression about the paper, whether it should implement any change on clinical practice. So if you're able to understand the statistics, you're able to make a full judgment on the whole paper. Would be.
Yeah, so I'd agree that if things like number needed to treat, to take the example I mentioned with digoxin for heart failure, if you would need to give 200 people digoxin to stop someone decompensating in heart failure, that's not very useful. So having a good grasp of the statistics will help you answer the other questions as well. But yeah, they might go slightly into, well, what is a p-value? What's a confidence interval? And again, those are things that you can prepare for, and you can have not a rehearsed answer, but you can practice those questions before the interview begins. Any other questions from the audience as well on maybe the academic side of things? Also keep in mind that for not all, but for some interviews, you do get time in advance to make notes. So for my London one, I had half an hour for both stations to look at the clinical scenario and the abstract and make notes on both, half an hour in total altogether, but I couldn't take the notes in with me. Was that similar for yours?
Mine was different. In Wessex, you didn't know anything before going in. Actually, no, that's a lie. You sat outside the room for 5 minutes, and I think they'd given you a laminated piece of paper which said the scenario on it, but that was it. You weren't allowed to make notes. You could think about in your head, okay, how am I going to approach this? The same as you would in the ward when a nurse has called you about a sick patient. You'd still go through the structure in your head and think about potential diagnoses. And then in Northwest England, I think I had 5 minutes again outside, and they gave you one piece of A4 paper that you were allowed to use. For the critical appraisal station, for me, I think I was the very first person that day, and they told me I couldn't take in the data with me, and it wasn't available inside the room. So I was there trying to very quickly write down everything I could about this paper, and then I did most of the station, and they were like, oh, you don't actually have the data in front of you. Here you go. And I was like, oh, no. So I was there 5 minutes, just very quickly to jot down things that I could use, and I did have that paper in front of me. And again, with the clinical station, I think they did give me the scenario, and I had 5 minutes to look at it, and I could take the paper with me. So it varies per place, but I think they do let you know that information prior. And I obviously reflect the fact that it's probably going to be a bit different this year, with most of them being via Teams or another platform.
So on that topic of online interviews, I mean, obviously we can't comment on how will they work this year because we didn't have online ones. But I think one point you mentioned earlier, Becky, is how they may have 5 questions to ask you. And you can end up spending all of that time on the first question. I think one challenge with the online interviews, any online interview, is you do need to slow down your pace a little bit. So I think if both of us were chatting to all of you in a room right now, we could probably speed up a bit. But in order to allow for internet issues, to allow for people to stop in the middle of your answers, slowing down for online interviews is quite important. Having things like a good internet connection is obvious, but obviously kind of closing anything else on your computer, treating it like you're in a room with them, so dressing appropriately. Having a simple, non-distracting background generally works well for online interviews as well. But I think the other key thing to keep in mind is, if this is your first ever online interview, it's probably everyone else's first online interview as well. Yeah. Any other areas of the interview, Becky, that maybe we haven't touched on? Anything else you thought you were asked that we haven't chatted about yet?
I was thinking earlier, I think the only thing we haven't really touched on is the fact that they could, I think sometimes the critical appraisal can take the shape of a paper that you've recently read. So they can ask you questions about, tell me about a paper you've recently read. So just have a read of a couple of papers in the few weeks before, the couple of months before your interview, and just be confident using the PICO format to speak about those papers. Yeah, I think they won't go into this detail because they're not going to know the ins and outs of that paper, and they're not going to have, everyone's going to have their own example, but it shows that you have an interest in research outside of answering their tick box questions. And it shows what you're passionate about. So don't go reading something that you think probably is just going to be of their benefit. Read something which purely interests you and gets you excited and would be relevant to the research that you potentially would want to do there. That's probably my other point. Oh, sorry.
No, I was going to agree that so this wasn't so much in my London one, but my Newcastle interview did go a lot into the previous research I'd done, what sort of research I'd like to do. And I know places like Oxford have often asked that question of, tell us about a paper you read recently. It's a lot like medical school interviews where you might have been asked, tell us about a healthcare article that you've read in the last couple of weeks. It's that sort of thing. And it makes you think, firstly, oh no, does that mean everyone else is reading papers all the time? No. Again, I think the really academic people are, but I'd say on the large part, most people have probably read a couple of articles in the weeks running up to their interview. And I think it's definitely worth doing so, not just for this question, but like you said, you can sit with an abstract and you can just go through and practice using the PICO method that we mentioned earlier, trying to think about the bias in that abstract. So it's just like practicing hematemesis, practicing chest pain. It's the same sort of thing. You're just running through example stations. But yes, at least having a couple that you can then yourself chat about in an interview. And it might be, okay, well, why did you find this research particularly interesting? What drew you to it? And again, pick things that have relevance to you. So what always looks very forced is when people would pick a paper that they actually find really boring, that they've just picked it because, oh, it was the top result on the BMJ that week. But actually it's something that they find mind-numbingly boring because their answer is going to show that they just read it for the sake of it. Whereas if you pick something that's relevant to maybe a specialty that you like, something that you encountered on the wards recently, and you can show them the connection of, well, why did you actually go and read this? That will be more impactful. One thing I think you touched on earlier, Becky, as well, is showing that you put a little bit of work into researching that actual area. And for example, if what current academics are there in those hospitals, and have you contacted any of them about doing a research project? So is that something that you did before yours?
Yes, so in both North West England and in Wessex, I contacted people just to say, hi, I'm applying to the AFP, I'm putting this as my top choice. I just want to know what kind of research might be available for me to get involved in. And generally, they were all really responsive. I had some great projects set up, or potential areas to focus on, and some really supportive sounding potential supervisors. And nothing's set in stone. But I think generally they quite like that people want to come to their area and people want to work with them. And for them, it's probably quite a positive thing being contacted by a final year student who wants to do the AFP with them. And I did touch on that in both of my interviews. I don't know whether that's what they're looking for or not, but I did mention, so tell us why you've applied here. I've applied here because of XYZ. Oh, by the way, I've also contacted this person. They've mentioned this research project that I could do, and I'm getting really excited about that potential. And then they may ask you a few more questions in response to that, or they may just move on. But I think it does show some real initiative, and it shows that you're really dedicated to that particular region if you've actually taken the time to set up a project or potential project. It doesn't have to be set in stone, like I said.
Yeah. I think this is something that very much caught me out in my Newcastle interview, because I got that question of, they said, what sort of research would you like to do during your academic block? And I kind of very much panicked, because I didn't realize that until I got to the waiting room of my Newcastle interview, that you chose what you do for 4 months. Because I knew elsewhere that often you got given at least a specialty or a theme. So I very much on the spot had to kind of think of something and dug myself into a deep hole, because the question I then got followed up with, oh, you want to do research on X topic? Have you contacted anyone in the area about doing anyone you know of who you could do that research with? Which I obviously could not just lie through my teeth about, but had to say, no, sorry. Still got the offer in the end, but definitely I was aware that probably impacted on my performance in that interview. London, in contrast, because it's such a large kind of deanery or academic area, you wouldn't really get questions like that, because there's over 100 posts in the London area, and they don't have enough time in those 10-minute interviews to explore it. But I think for those outside of London, it's often more common for them to see, well, have you put the time and effort into seeing who we have in academia locally that you could work alongside? And I know places like Cambridge are very specific on that. They want to see that you've rocked up to the interview with an idea of what you want to do and who you want to do it with. Like Becky said, not set in stone, but that you've shown, again, some thought in advance.
Yeah. And with that on mind, I was just very quickly going to say, if you are contacting people, I found it very helpful to have a CV created and to attach that to the bottom of your email to them. Just get emails off of the hospital websites or the university websites. But if you attach the CV, because usually if you don't attach it, the first question they'll say is, can I see your CV? And if you've already done that, then you've already taken one step beyond.
Yeah, exactly. Most academics are incredibly busy. The fewer steps for them between you contacting them and then some sort of outcome, the better. If they are going to have lots of back and forth, that puts more chance that they might just get too busy and either miss your email or not have time to reply to it. I completely agree. Any other questions in the chat then? I think we've probably touched on the main themes that you'd all see in your AFP interviews. But to recap, kind of your key stations are clinical and academic. Clinical being mainly your A to E, but often with a little bit of professionalism and ethics involved. And then the academic being your critical appraisal, which may also touch on your own interests, either in research or other topics as well. But I think, yes, they're a little bit daunting at first, but I'd agree with what Becky said at the start, but both interviews I found incredibly helpful, because whether you're successful or not for an AFP interview, remember that the next time you'll probably have an interview like this is when you're applying either for core medical or surgical training, or you're applying for specialty training. So the majority of people who go into those interviews have had no interview experience since medical school. Whether you are successful or not, make the most of that opportunity, because you'll take a lot away from it. They'll be really useful in 2 or 3 years' time when you're going through the same thing again for specialty applications.
Yeah.
Anything else you'd want to add about interviews in terms of any other resources you use to prepare, Becky, or any other kind of key tips and tricks?
I can't remember any other resources that I necessarily used, but that book was very helpful. And I do think if you have any willing friends who aren't applying to the AFP or friends who are applying to the AFP, practicing with them would be one of your best decisions and probably one of the most helpful things, because you can just get feedback about the annoying things that you do when you don't know the answer to a question, or the annoying habits that you have. And with that in mind, I probably would also, if it were me this year and I was doing an interview on Teams or another form of video conversation, I would probably practice a mock interview on Teams, because you could get a friend to sit in a different room, a different house, and give you feedback about how you've performed answering questions when you're just sat in a room by yourself. But that would just be my what I would do this year, and I think many people probably would.
And I think obviously for the next month, a lot of you will be limited to that being your main way of practicing with friends. So even if none of the people in your own friend group are applying for the AFP, it'll definitely be people in your year. So if you have a year Facebook page or any other kind of social media for your year, even just putting out a message saying anyone else applying for AFP want to form a group, definitely worth it. And it seems like a lot of effort to do on top of final year. Anyone who is in final year right now has probably just applied to FPAS this week. On top of that, you've also got the SJT towards the end of the year. You've got finals, you've got placement. I know you'll have a lot of things going on, but as we said, this practice is not only helpful in the future, but like we mentioned at the start, that a lot of especially the clinical side of things, is massively helpful for finals anyway. And all of the ethics and the professionalism is massively helpful for the SJT. I think my SJT was, I think the week before my London interview, and I found that it was really useful for both to have them close together, even though it was a bit stressful at the time. Each one helped one another. One thing I'd mention as well, that I as well probably found that my academic interviews were weaker than my clinical ones. But what you'll find, I think, in most areas, the clinical one might not be worth more points, but often you will need to pass it, because the key thing they're assessing is safety. If you're going to work in an AFP, you've got 4 months less time in a clinical post, and therefore you've got 4 months less time to build up competency as a doctor. So they want to be extra sure that you've got the knowledge and the competency to be okay with that and to not suffer too much as a result. Anything else you'd add, Becky?
No, I was just agreeing to everything you just said.
We do have about 5 more minutes left if anyone's got any particular questions. We've both just left so both of us, if you do want to drop us a message or add us on LinkedIn, our details are there as well. I've also just left the kind of key resources that we mentioned there as well. And a lot of them you can probably find, I probably shouldn't say, but you can find free PDFs online. I'm guessing they're probably not legal, but a lot of these you can find for free online. Or if you have friends in older years who might have gone through the process before, they might have a secondhand copy anyway. Or obviously your university library is another good one as well. Most of these you'll find in a university library. So we'll leave it for the next couple of minutes if anyone's got any questions. I hope that we've given you a good overview of interviews. Obviously, we can't tell you what will turn up in your own interview or what will turn up everywhere, but I'd say the themes we've touched on today are probably the most common things that you'll see. And we've mentioned some resources, we mentioned some key structures, but also some of the kind of the challenges that a lot of people face. So if you're struggling in a similar sense, don't think that you're the only one with that challenge. It's almost universal for people going through the process. And yes, online interviews are a bit bizarre, but I'd agree that if you're in a group and you're practicing via the online format is perfect. So I think that's it. Thank you everyone for listening to us. We'll wait around for the next couple of minutes in case you've got some questions, but apart from that, best of luck to you all with your interviews.
Yeah, good luck everyone.